Kathy. So we're going to talk to you today about the work we've been doing within the CVD COVID UK consortium to characterise COVID-19 related events in a nationwide electronic health record cohort in England. My name is Chris Tomlinson. I'm an anaesthetic and intensive care registrar doing a PhD at the UCL Institute of Health Informatics. And this is work done with Johan Thygesen, a lecturer at the IHI, Spiros Denaxas, but contributions from many other consortium members. So the objectives of this piece of work were to develop computable, reproducible phenotypes for COVID-19 events under the broad categories of diagnosis, treatment, and outcome, to then determine overall disease severity on an individual level, to examine the characteristics and trajectories for those COVID-19 events identified, and to share research-ready assets for other users in the TRE. We'll start off with this rather busy flow diagram, which illustrates the process by which we identified our events. On the left-hand side, you can see 7 different data sets across testing with SGSS from Public Health England, primary care encompassing GDPR, secondary care, and Office of National Statistics Death Registry. From these 7 data sets, we then extract 10 distinct COVID-19 events under the 5 broad categories of testing, primary care diagnosis, hospitalisation, critical care, and deaths. On the right-hand side, you can see the numbers of events that we've identified and the numbers of distinct individuals experiencing each of these events, as it is possible for an individual to receive, for example, more than one test or diagnosis. Moving on to illustrate how we defined the cohort for this work, which with such a large data resource was certainly a non-trivial experience. So it's important here to consider that one of our aims is to provide a research-ready resource to the TRE. And so we started off with a maximally inclusive approach at first, whereby we identified patients from across every single data set, and that identified about 3.9 million individuals. In order to really firm up a defined cohort for this study, we reproduced the methods used in the descriptive paper by Angela Wood et al. And we took individuals into the cohort if they were alive and registered in GDPR at the start of the study. For our study dates, we used the 23rd of January 2020, the index case of COVID-19 in the UK, as our start date, and went up until the 31st of March 2021, which was the last common cut-off date across all our 7 data sets. We made sure that participants with non-fatal index events who had less than 28 days of follow-up were excluded. So in other words, each individual enrolled into the study was given 28 days to declare their outcomes. This produces a final number of 3.4 million individuals with COVID-19 events, just slightly under the 3.7 million identified using the Public Health England COVID dashboard. So these are kernel density plots illustrating the frequencies with which these events were identified over time. So starting off in March 2020 on the left-hand side and running for a year up until March 2021 on the right. On the left-hand side, it's the 10 distinct events we identified, and the right-hand side shows the data sources. This is a rather busy slide, but the key points that I want you to take away are that we mirror the bimodal distribution of the pandemic seen in the UK. What's really clear from this diagram, if you look at the top left, you will see testing in green, and you can see the limited amounts of testing occurring at the start of the first wave, where there's a really small peak in testing, particularly when contrasted with the hospitalizations in orange below and deaths in grey at the bottom. And this really illustrates the strength of our approach in capturing individuals, not simply relying on testing, which we know has had a troubled time through the pandemic. Another takeaway from this graph is simply the difference in magnitude between wave 1 and wave 2. Now, these are logarithmic scales, but if you look at, for example, hospitalizations in orange on the left, which is independent of testing, you can see a much greater area under the curve for wave 2 than wave 1. I appreciate this is a kernel density plot, so there is some smoothing in there, but nevertheless, I think it's fairly clear. Now, an even busier slide, a sort of table 1 describing the characteristics of individuals with these events. So in the column on the left highlighted in green, this is all individuals across all the COVID-19 events that we've identified. So representing our best possible indication of all those infected. We then have those hospitalized in red column, those admitted to intensive care in the purple column, and those who died in the grey column, with each of those stratified for comparison. Now, I wanted to present this just to show you the level of characterization that we've done, but whilst it's here, I'll just highlight a couple of key findings. So we can see that of all individuals with COVID-19, about 10% of those are hospitalized, and the overall mortality rate is about 4%. But by stratifying with hospitalization and intensive care, you can see that the inpatient mortality rate is 28%, and the mortality rate in those admitted to intensive care is 40%. This is across the entire pandemic. We've also reproduced known findings with regards to differences between the sexes, ages, and ethnicities. But for further details, I will direct you to our forthcoming manuscript. I'll now hand over to Johan to describe the trajectories.
Thanks very much, Chris. So another interesting thing we can do once we've identified COVID-19 events across this, all the individuals in the TRE, is we can perform patient trajectory analysis. And we have 3 simple steps we've taken to do this approach. So first of all, we've simplified the COVID-19 events, basically grouping together the ventilatory treatments into critical care and all the different types of deaths into deaths. We then order the events for each individual by date and severity. And finally, we only include the first mention and date of any of these events. So you can see here, this individual here, looking at the full trajectory, had 2 positive tests, one on the 4th of May and another on the 7th of May. But in the final analysis, we only include the first mentioned, the one on the 4th of May, and the same for the 2 critical care events identified. They may be different types of ventilatory treatment, but we only include the first one and the first date. Analyzing the data like this, we identify 139 unique trajectories in the 3.4 million individuals included. And we can see here the top 10 most common patient trajectories. So around 50% of the patients had a positive test followed by a GP diagnosis. And the most common trajectory, including hospitalization, was again positive test, GP diagnosis, and then hospitalization, which was found in around 2% of the individuals with COVID events. Now, we thought it would be interesting to look at these trajectories in relation to wave 1 and wave 2 and compare the 2. So what you see here is a timeline plot again of these simplified COVID-19 events, and the lines in red indicate the official lockdown dates, and the lines in blue are our sort of approximation as to when wave 1 started and ended, and similarly for wave 2, the start and end date. And in the following analysis, we include only trajectories found within those two outer boundaries for wave 1 and wave 2. So what you see here is a network plot, basically showing all the transitions between these different 5 events. So the circle sizes are relative to how many people had this COVID event, and the number on the arrows are relative to the total percentage of people who had that particular transition. So say from positive test to hospitalization, we saw 16.3% of all the transitions were between those 2 event types. And we can then compare wave 1 with wave 2. If you click, Chris, yeah. So here on wave 2, you can see, as Chris mentioned earlier, there are way more positive tests and GP diagnosis. And since we're sort of comparing frequencies here, so the percentage of transitions between the 2 waves, it can be a little bit difficult to compare, but what we're seeing is basically that in wave 2, more of the transitions were between the positive tests. This is sort of hiding a little bit the fact that there were actually more hospitalizations on the wave 2. So we're still sort of developing these types of plots and figuring out how we can showcase this better. But we can also calculate the median days between events. And this is more directly comparable between wave 1 and wave 2. So what you see on the arrows here are the median number of days between 2 event types. And in general, what we see is that wave 2 has longer periods between these events than seen for wave 1. This may again be some sort of a reflection of more testing and maybe earlier testing for individuals in the time of when they got infected in the first place. So I think there's many interesting things to pull out of this, but these are also relative new plots for us, so we're still sort of getting our head around what's interesting to pull out here. Yeah, so as Chris said in the beginning, a big part of this project was to create shareable phenotypes, and we now have 3 tables in the TRE that can be accessed by every researcher in there. We have the first table, which is a COVID trajectory, which basically lists all the events for all individuals, including the date, which data source it comes from, what code has been used to capture that particular event. Then we have a COVID events table, which just gives a binary flag, true, false for each event type. And then finally, we have the overall severity, which basically measures the most severe outcome for each individual patient. And all of these can be found within the CoLab database. So in conclusion, we've done a somewhat comprehensive description of COVID-19 events derived from linked electronic health records on a national scale. And we hope that these COVID events will be useful for other researchers to stratify their work or look in more details of with regards to whatever their specific focus is. So thanks very much for listening, and big thanks to everybody who's given a lot of input on this data, on this research.